Hello everyone, my name is Faisal Jahangiri, and first of all I would like to thank the organizing committee for inviting me to talk today. So today I'm going to talk about transcranial motor evoked potential versus direct cortical motor evoked potential, how we can enhance the patient safety and surgical precision using these techniques. So this is just a brief introduction about myself. I am currently Director for IONM Fellowship and Diploma Programs and President of Global Innovation in Dallas and Texas. I'm also past President of American Society of Neurophysiological Monitoring and also Assistant Professor of Instruction in Department of Neuroscience at the University of Texas at Dallas. I'm also adjunct professor in Library College in Massachusetts and faculty in Lawrence Technological University in Southwest Michigan. I'm also chief editor of the new journal, which is Journal of Neurophysiological Monitoring, if anyone is interested in submitting their articles. I have no disclosure, conflict of interest to disclose for this talk. So the goal of this talk today presentation is at the end of the presentation, we will be able to understand the motor pathways and understand the difference between direct cortical stimulation and transcortical stimulation in regard to recording and stimulation setup, stimulation parameter, the anesthesia requirement, and the surgical application of these technique. So I decided to check with ChatGPT is okay what that says about MEP. So I got this response that motor evoked potential are electrical signals generated in muscle following direct stimulation of the motor cortex. These signals are used to assess the functionality and integrity of the motor pathways within the central nervous system, particularly the corticospinal tract. So motor evoked potential can be broadly divided into transcranial motor evoked potential and direct cortical motor evoked potential. And transcranial motor evoked potential can be divided into transcranial magnetic motor evoked potential and transcranial electrical motor evoked potential. The direct cortical motor evoked potential can be done by direct cortical stimulation and subcortical stimulation. So when we're looking at the homunculus of the person, as we have seen, homunculus is a presentation of the sensory and motor uh, area of the body on the brain, where the foot and leg areas between the two hemisphere, and face and hand and area are more lateral. Face and hand are the most have a largest representation because of the functionality and more complex work done by the facial expression and the hand movement. So both have these one, and so when we are doing transcranial motor evoked potential, so we want to have this image in our mind because we want to place the electrode in the precentral gyrus, which is the motor area, to make sure we can activate these fiber without going too high in stimulation and with a minimal patient movement. When we are doing direct cortical stimulation, so our purpose is to identify these areas by recording from all these muscles and localize sensory area versus motor area. And motor area we can tell which area is the hand, face, leg, and foot area. So just like brain homunculus, we also have spinal homunculus, which is a presentation of the motor function of the body. So more proximal muscle are close to the midline, and more distal muscle are on the lateral side. So if there's any damage or ischemia to the lateral cord syndrome, it will affect your more distal muscle, hand and feet. If it is the ischemia or damage to the central cord syndrome or central area, it will be affecting more proximal shoulder or hip muscle than the other muscle. So if you look at the motor, it's important to just review the motor pathway before we go into details about the motor track and the stimulation area. So we know that we have four lobes: frontal lobes, parietal lobes, temporal lobe, and occipital lobe. So the sensory and motor area is divided by central long central sulcus, which separates the primary motor gyrus with the primary sensory gyrus. So primary sensory gyrus is the first gyrus posterior to the central sulcus and known as S1 or Brodmann area 1, 2, 3. And the primary motor gyrus is the first gyrus which is anterior to the central sulcus, also known as Brodmann area number 4. And so this primary motor gyrus or primary motor gyrus or precentral gyrus or Brodmann area number 4, it is responsible for all gross movement. So the sulcus anterior to the primary motor gyrus is known as premotor sulcus. So precentral sulcus. The sulcus posterior is the central sulcus. The sulcus anterior is precentral sulcus. And the gyrus anterior to precentral sulcus is known as premotor gyrus. So premotor gyrus is the gyrus anterior to the primary motor gyrus, and it is responsible for fine motor movement. And then gyrus anterior to that is known as visual eye field, which are responsible for eye movement. So when we're looking for all these fibers, so 1/3 of the motor fibers they originate from primary motor gyrus, 1/3 originates approximately from the premotor gyrus, and about 1/3 they originate from post-central gyrus or sensory gyrus. So all these motor fibers they come down and they travel lateral to the thalamus. The thalamus is a gateway to the brain, sensory gateway. So there's no motor fibers going through the brain, to the thalamus. They travel outside the thalamus. So if there's any damage to the thalamus, it's not going to affect our motor signals. So the fibers they are coming down from the cerebral cortex. They are from Brodmann area. They originate above layer 5. There are 6-7 layers in the cerebral cortex. So layer 5 is the where the cell bodies of these pyramidal cells, and these cells come down, and the fibers which are responsible for head and neck movement they leave at the brainstem and make synapse with the nuclei of all the cranial nerves at the brainstem around fourth ventricle. And those fibers, and then those fibers are known as corticobulbar tract. Now, motor fibers, there are two fibers in sensory. There are three fibers from stimulation to the brain. In the motor tract, there are two fibers from the brain to the muscle. The one which start from the cortex, from the Brodmann area 4, layer 5, pyramidal cells, those are known as upper motor neurons. And the fibers, they start, and those upper motor neurons, they start from the cerebral cortex and make a synapse with the lower motor neuron in the anterior horn cells. And the lower motor fibers, lower motor neurons, they start from the anterior horn cells and make the synapse in the neuromuscular junction. So if there's the function of the lower motor neuron is to have contraction and like flexion, extension, abduction, all the function, and the function of the upper motor neuron is to inhibit and to keep the control. So when the upper motor neuron is damaged, if there's no inhibition, so the lower motor neuron contracts more, and it causes spasticity. When the lower motor neuron is damaged, that is attached directly to the muscle, so it doesn't contract whatever you do. So that will cause flaccid paralysis. Now, if you look at this zoom out image of the corticospinal tract and corticobulbar tract, so the fibers they are originating from foot, hand, and face and head and neck area. So the head and neck area fiber they're coming with the corticospinal tract, but they leave the brainstem and near medulla oblongata and make synapses the nuclei of the head and neck cranial nerves to supply the head and neck muscles. The corticospinal tract, however, they come down, and at the lower medulla, the 80% fibers, about 80-85%, they cross over to the other side, and the 20% remain on the same side. The 80% they cross over, they stay on the lateral spinal cord, and this is known as lateral corticospinal tract. The one they don't cross, they stay on the anterior part of the ipsilateral spinal cord, and those are known as ventral corticospinal tract. So the lateral corticospinal tract or the crossover corticospinal tract, it's controlling the upper and lower limb muscles or upper and lower extremity muscles. The fibers that don't cross, they eventually cross at every segmental level. So they cross at C1, C2, C3, C4 until sacral levels. And these fibers, they they supply the non-limb muscle or like trunk muscles. So if you look at the corticobulbar tract, so this is a tri-dimensional drawing of corticobulbar tract, which shows three main branches of CBT. Pink is the midbrain, and red is the pontine level, and yellow is medullary. So they live at the different levels. So, so when we're doing transcranial magnetic stimulation, we have this TMS machine, and it can be used with navigation. So if we use with navigation, we call it navigated transcranial magnetic stimulation or NTMS. So this is done preoperatively to identify the area or the function of the motor fiber. And patient, this bed number 9 is the chair where the patient is lying, and the physician is holding the tracker coil, which is number 3, the tracker coil, to head the tracker and look for location and movement of the head. So the head tracker is for the location of movement of the head, number 2, and the coil tracker is for location, orientation, and tilting of the coil. So, and then on the screen, so we can see, according to navigation, we can see the responses on the screen. So when we're seeing the screen is the E field navigation, which is electric field, which is created due to the stimulation. And the upper picture, we show the responses from APB and ADM, so hand muscles, and about 110% of the recommended repetitive muscle stimulation. At the bottom one, we can see the responses present, but it is before that at the same time, and the screenshot shows the leg area mapping of 3 targets muscles: tibialis anterior, abductor hallucis, and gastrocnemius, because abductor hallucis muscles also originate from the leg area. So transcranial electrical stimulation. So in transcranial magnetic stimulation, we are doing magnetic stimulation. If you use a transcranial electrical stimulation, that will be transcranial electrical stimulation. So I just wanted to share you, when I started monitoring, this was the 4-channel machine I have. So, and there was no operating system, and the operating system was on floppy drive. So every time we have to upload, we have to turn on the machines, we turn on and put a floppy drive and upload the operating system in the server and in the RAM, and then use the machine. So, but this was 4 channels. So every time you have to do motors, you have to unplug EMG and plug EMG, and when you do to SSCP, you unplug SSCP and plug EMG. So we can switch between EMG and SSCP. Later, in the early 2000, a device was approved by FDA, called DigiTimer, the British device, and then they have DigiTimer 100, then we have DigiTimer 150, and then more sophisticated. But this was the first device which was approved by FDA for use of motor evoked potential, and it was placed on top of Cadwell and sometime other machines, Medtronic, Cadwell, Bravo, and all the Endeavor and Exceltech. All these machines, they were not approved by FDA at that time. So we're using Digitimer, this equipment, and it was connected through a cable, external cable, and every time you stimulate from the motors from the Digitimer, but we do recording from our IONM machine. So later, this is me in Philadelphia about 20 years ago, early 2002, 2003. So this is a 16-channel machine, and this 16 Bravo machine was also not approved for motor evoked potential. So we had this digitimer attached to this and connected through a cable, and we use using digitimer for training purposes and monitoring purposes. So what is direct electrical cortical stimulation? So the first cortical stimulation paper, I was trying to see the paper where is the start from that. So I saw this first public cortical stimulation publication was in the late 1700. So this was so gross, the spectaculars, they fled and they banned this procedure later. So this was the electrification of decapitated of heads by electrical current, and they were looking for any responses. In early 1980s, Dr. Ogeman, he developed another stimulator which is still being used. It's called Ogeman stimulator. It's not being manufactured, but most of the hospital system, they still have the old machine. So Dr. Ogeman, which is Professor Emeritus of Neurology Surgery in Department of Neurological Surgery in University of Washington School of Medicine. So this is name, and then it comes with a probe, which should be used only for 5 tons according to manufacturer, but it has been used for a very long time. So we use different parameters. It's a low current stimulation. Maximum current you can go on this machine is 20 milliampere. Now we have different machines which can go 32 very easily, 32 channel, and sometime more than 32 channel, maybe 70 or 100 channel. So goal of neuro monitoring, there are two goals of neuro monitoring when you're doing transcranial motor evoked potential. They are to protecting the corticospinal tract and then minimal post-operative deficit to improve the quality of life. So we do motor evoked potential, and the purpose of doing transcranial motor evoked potential is to protect the corticospinal tract during high surgery and making sure the patient has minimum post-operative deficit and improving the quality of life of this patient. The purpose of doing direct cortical motor direct electrical cortical stimulation is to maximize the tumor resection to improve the patient survival. So if the tumor is malignant and have left and chance of survival is less, then you want to do maximum tumor resection so patient chance of survival is improved. So we want to use that, and then minimal post-operative deficit while we are stimulating. So more chances, more resection you do, more chances with the chances of damaging the normal tissue. So recording of the motor evoked potential. The recording for transcranial motor evoked potential can be done depending on the muscles or the level of surgery, but typically it's done bilateral stimulation and bilateral recording. So the recording for the upper extremity and lower extremity, the muscle we use for upper extremity are typically deltoid, biceps brachii, brachioradialis, flexor carpi and ulnaris, first dorsal interosseous, abductor pollicis brevis, and abductor digiti minimi. For the lower extremity, we use record from the adductor muscles, quadriceps muscle, tibialis anterior, gastrocnemius, and abductor hallucis, and extensor hallucis brevis muscle. And we also use external urinary sphincters and anal sphincter muscles for recording motor evoked potential. So MEP should be done bilaterally. It should be done on upper extremity and lower extremity. If it is a thoracic and lumbar area, then just hand muscles are enough to have a control. If it is cervical area, then we have to have all the muscles in the upper extremity, most of them, and also and then muscle from the lower limbs as quadriceps, tibialis anterior, and foot muscle, abductor hallucis. So we do upper extremity and lower extremity, but and for the lumbar area, thoracic area, so surgeries we should be doing sphincter muscle because sphincter muscles also important, and if there's an injury, we can be able to identify. So if you are doing the recording for direct electrical stimulation, we do contralateral recording only because we stimulate the one side of the brain where surgeon is operating, and then we are recording from the upper face, upper extremity, and lower extremity. If the patient is not awake, then we can also record from tongue muscle, but typical muscles to record is orbicularis oris and mentalis muscle. Oculi, you can do recording for oculi, but the oculi is very close and it has large stimulation artifact, so we preferably not do that. But if you do oris and mentalis muscle, that's good for facial nerve monitoring. We can also record from the upper extremity all the muscles we use for TCeMEP and for upper and lower extremity. So let's talk about the stimulation parameters which are used for the transcranial motor evoked potential and direct cortical stimulation. For transcranial motor evoked potential, the most common site which are used for the stimulation are C1, C2, C3, and C4, which are placed after measuring the head. So you should always measure the head with according to international 10-20 system and localize that areas and then place the electrode. Because if you are just ballparking and just using your hand or just eye vision and without measuring the head, then you may not be as exact place. So if you are a little bit off the place of the motor cortex, you will not be able to get a response at very low current. So you have to stimulate at very high, and so that if you stimulate very high to get the same response, patient will jump, patient will move, and surgeon will say don't stimulate. If you have a very precise location, you measure the head, use the measuring tape, and do according to a 10-20 system, international 10-20 system, measure the head and place the electrode. You should be able to get a response at a very low voltage, and if you get a low voltage, you can stimulate more frequently and get a better response at very low current. You can also place the electrode on alternating side, which is M1, M2, M3, and 4. So these are the M1, M2 on the M1 is M3 is the left side, M2 is on 4 on the right side, and there is 1 centimeter anterior to C1, 2, 3, and 4. So for the stimulation site for transcranial motor evoked potential is a direct cortical stimulation. So when you're stimulating the cortical area directly or subcortical area, and the option we have is either using a monopolar probe, handheld probe, or a bipolar probe. We can also use the cortical grid as a monopolar or bipolar, but if the surgeon is doing the stimulation, we use the monopolar handheld stimulator or a bipolar handheld stimulator. So it allows us to activate the muscle of the face, upper and lower extremity. So we can do direct cortical stimulation with either handheld stimulator or grid stimulation. So the probes we have for two types of probe, we have either monopolar ball tip electrode. So we have to make sure we are using a ball tip electrode. We are not using sharp fine tip electrode because that can cause damage to the brain. So we always use ball tip electrode. It has a bigger surface area, it can activate more area, and you can get very good responses. So either you can use monopolar ball tip electrode, the same probe which is used for pedicle stimulation, or we use bipolar electrode which has a two pole. So here we can see the stimulation probe in the upper part of the figure. You can see the probe with the homogeneous field. So the bipolar probe has a very homogeneous field, and it is very focal stimulation. And comparing to the monopolar probe, where there's a more current spread and it spreads to the other more area, so it has more sensitivity but less specificity as compared to the bipolar, which is more specific and but less sensitive. So for transcranial stimulation, so when we are stimulating, we are placing these electrode on C1, C2, C3, C4, and just using the best thing is to use corkscrew electrode. So we use corkscrew electrode because corkscrew electrode have a bigger surface area and it have less impedance, current impedance, so you can activate the fiber at a lower current, and you can be more, and they are more secure, so less chances of coming out. So the area under the anode is activated more than the area under the cathode. So that's one of the reasons it is known as anodal stimulation. Not that anode is the current is not coming from anode, the current comes from cathode to anode, but the area under cathode and anode both are activated where more activation in the anode. So when you're doing transcranial motor evoked potential, we always record the muscles opposite to the anode on the brain, on the scalp. And when we are stimulating the direct cortical stimulation, we are doing contralateral stimulation always. So when we stimulate, we can do two type of recording, either or both of them. If the spinal cord is exposed, dura is exposed, we can do epidural electrode, which is a grid electrode which is placed on the epidural space above the dura. In some cases, it can also be, if the dura is open, you can also place subdural, but epidural is a typical, and those responses are called direct wave responses or D wave response. The indirect activation of the brain can also activate and cause I waves, which have more synapses. So D waves can be produced by single pulse, and it has least or very minimum effect on by anesthesia, and the muscle action and anesthesia gas, they don't affect a D wave, but motor wave potential disappear with with the muscle relaxant, and with the natural agent is significantly altered, and you are unable to record if you have high anesthesia. So for transcranial motor evoked potential, we can stimulate and the signal comes down in upper extremity and lower extremity, and the epidural electrode give you our D wave recording, and the muscle responses give you our muscle responses. So here on the left side we can see the surgeon is placing this electrode. So this is the epidural electrode. This is the dura. You can see the dura. This laminectomy done. Dura spinal cord is exposed, and surgeon is putting. So these epidural electrode comes in two sizes, three sizes: contact 1, contact 2, and contact 3. So this is a 3 contact electrode which has 1 centimeter distance between each contact. So we can record from contact 1 and 3, which gives you a much higher sensitive response. On the right side, we can see that after this place of electrode, the surgeon made the incision and the dura is open. The surgeon make incision inside the spinal cord, and it's opening that cystic area and removing the tumor. So, and while your surgeon is moving, so we have one grid above and one grid below, and so we are recording D wave above the tumor and below the tumor at the same time. And if there's any change delay, we can identify and immediately report to the surgeon. So this MEP, D wave MEP can be done without patient movement, and nobody realized that you're actually stimulating. With transcranial muscle MEP, patient will jump, so you cannot do while the surgeon is inside the spinal cord. So these are the recordings. So we have stimulation with C1, C2, or the one other option is CZ to CZ to 6 centimeter anterior. And these are single pulse will give you D wave, and then we can also get D wave and I wave. So if the anesthesia is high, they have I1, I2, I3. They start disappearing from I3 and then I2 and I1. So this is so for direct cortical stimulation, direct electrical cortical stimulation. We have stimulation with constant current stimulation because there's a very low impedance area. For transcranial, we stimulate with constant voltage stimulation because the voltage is high, so impedance is high. So when you stimulate constant voltage, V is equal to IR. So if the resistance is higher, the current will be low. So here we are stimulating when if the resistance is, and for constant voltage, that is low, the current will be very high. So that's why we don't use direct cortical stimulation with constant voltage, because resistance is very high. So it will inject very high current. But we want the control on the current, because current is the one which can cause damage. So if your current is controlled, and if the I is equal to V over R, so if the current voltage is resistance is low, the impedance if the resistance is low, the voltage will also be low. So we use constant current stimulator, and then we stimulate, and then we can record from the different muscles, upper extremity and lower extremity muscles, and wherever they got. Here we are getting response for flexor carpal tunnels and abductor pollicis brevis, so we know we are close to the flexor hand area and the brain. So what are the stimulation parameters for TCeMEP and DCeMEP, and what is the safe stimulation? So for transcranial electrical stimulation, the constant, if you're using some equipment, IONM machines, they allow you to do constant voltage, some they allow you to do constant current, and some they allow you to do both of them. So if you're doing constant voltage stimulation, the only two options you have for pulse rate is either 0.05 microsecond, sorry, 0.05 millisecond, which is 50 microsecond, or 0.075 millisecond, which is 75 microsecond. And you can stimulate maximum of 100 voltage. And the constant current stimulator, with the pulse rate, you need a longer pulse rate, 0.5 millisecond or 500 microsecond, and you can stimulate up to 200 or 250 milliampere. The pulse train we use for upper limb muscles is about 5 to 7 pulses, But if you're doing cortical stimulation for the then we so we use 5 to 7 stimulation, 5 to 7 pulses with the ISI at 2 hertz to 4 hertz. But if you're doing corticobulbar MEP, we use 3 to 5 pulses and ISI of 2 millisecond and a single pulse. Uh, the frequency of stimulation range from 200 to 500 hertz. So constant current stimulation for direct cortical stimulation allow us to reduce much higher stimulation parameter than the TCeMEP. The intensity, if you're doing constant voltage, you can go up to 600 or 800 volts. And if you're going doing the constant current, then the maximum current is 200 milliampere. The energy is very important, which is E is equal to current I, W, pulse width, and resistance. So that means that 50 millijoule is the maximum current allowed. So no matter which machine you're using, so when you're increasing the current, you should decrease the pulse width. You can increase the pulse width if the current intensity is very low, but not with a high one. So double train stimulation is another parameter type of stimulation where we can stimulate two trains, and the first train causes the activation of the motor fibers, and the second train causes relay headed. So when you're doing double train stimulation, so we are doing two successive train. The total stimulation in both train cannot be more than 9 milliseconds. So you can use combination of different up to 9. You can do 4 plus 4. You can do 2 plus 7. You can do 2 plus 6. You you cannot do 5 plus 5 because that's 10. The interstimulus interval we use is about 1 to 4 millisecond. The inter-train interval is about 15 millisecond to as high as 150 millisecond because some patients have very delayed responses. Um, so ISI, so if you do ISI very short, you don't get enough refractive period to get a response. If it is too long, then you're not doing a temporal summation and you are doing just single pulse stimulation. Short, it says single pulse, but actually you're stimulating multiple times because you're averaging. So shorter ISI improves upper limb MEP and longer SI is for lower MEP. So if you're doing better lower. So this is the schematic presentation of the upper motor neuron from cortex to lower motor neuron, and lower motor neuron from the anterior horn cells to the muscle fiber. So motor unit consists of anterior horn cells, lower motor neuron, neuromuscular junction, and muscle fibers. So those four elements form the motor unit stimulation. So when you're doing direct electrical cortical stimulation, we have two options of doing two. Either you can do Penfield method or Taniguchi method. So we published this paper in 2022 about mapping of the brain with Taniguchi versus Penfield method. So if you need more information, this can be downloaded on the Curious website. So for Penfield is a short frequency and Taniguchi is high frequency. Penfield is used only for bipolar. You can do with monopolar, but the bipolar give better responses. Taniguchi can be done by monopolar and bipolar, but monopolar give you better responses. Um, Both can be done either biphasic or monophasic. Frequency is 50 Hz for Penfield and 250 Hz for Taniguchi. The pulse width is 500 microsecond for Taniguchi and 300 to 1000 for Penfield. And intensity is the same, 2 to 20 milliampere, and duration of stimulation is 2 to 5 pulses, 2 to 5 seconds for Penfield. And because you want to cause disruption in the speech, so you have to do a longer stimulation for Penfield. So that's why it causes more chances of seizures. Penfield, you want to go quickly response and just get the response, and that is used about duration is about 20 microseconds. So cortical mapping is done for sensory mapping, motor mapping, and language mapping, and for localization of epileptic focus if it's in that area. We want to preserve the vital brain function, language function, and motor function. It gives a real-time feedback to the surgeon, and we want to maximize the extent of resection while avoiding any new deficit in these patients. So when we are planning for cortical mapping, we can do cortical sensory mapping, which is phase reversal by stimulating the contralateral median nerve or ulnar nerve and look for the phase reversal. And for direct cortical electrical stimulation, we do bipolar gray matter mapping, monopolar gray matter or monopolar white matter tracking. We also do electrocardiography and EEG and EMG and trainer 4 in these patients. So there are different type of grids that we can use for cortical stimulation and recording for phase reversal recording and for cortical stimulation. They come in 1 by 4, 2 by 4, 1 by 6, 1 by 8, 4, 4 by 4, 8 by 8. So depending on the size of the exposure and the area which we are trying to reach, and if so we can use the grid of the appropriate size. So when we do cortical mapping or direct electrical cortical stimulation, the first step is to do phase reversal. And the reason we want to do phase reversal first is to identify the central sulcus. So the main purpose of doing a phase reversal, which is a sensory mapping of the brain, is to identify the central sulcus. Once we have this functional central sulcus, because the anatomical central sulcus can be seen by the surgeon or by navigation, but the area under the functional area under the central sulcus can be shifted. It can, if there's a tumor, it can shift the corticospinal tract anterior, posterior, medial, and lateral. We don't know where they are. So in order to confirm that, we need to stimulate the contralateral nerves and record a phase reversal or a sensory response from the cortical. So here we can see we have on the left side we have 1 by 6 grid we placed, and the blue arrow we can see this is omega, which is omega sign, which is done by the vein of Tollard. So vein of Tollard is one of the largest vein which is traveling in the central sulcus. So area inside the vein is pre-central sulcus. Pre-central is pre-central pre-central sulcus area, or also known as primary motor gyrus, and the gyrus posterior to that is the primary sensory gyrus or post-central gyrus. So here we can see on the right with the gray arrow, this is the tumor which is located in the most posterior to the central sulcus, and we have a grid here, and we can trying to do the phase reversal. Sometimes you don't see the phase reversal, so all you see is all post-central or pre-central responses. On the right side, we have a 2 by 4 grid, so we have placed a 2 by 4 grid with 1, 2, 3, 4, and 5, 6, 7, 8 on the right side. So some, depending on the manufacturer, 1, 2, 3, 4 grids may be on the left side, and 5, 6, 7, 8 may be on the right, on the opposite side. So you have to make sure when you're programming, so to where is the grid, and the programming should be done according of the sensory mapping of the brain. So we have placed the grid, a 6 contact grid on the cortex on the right side, and we are stimulating the median nerve on the left side. And we look at, so the generator is, this is the generator for the median nerve. So all these contacts, they are picking the same response. So the area, the red area is the motor gyrus. This is the omega shape curve, which is typically seen anatomical landmark for the central sulcus, and we see land of Tollard traveling in that. If you look at that, so grid number 1, 2, 3, they are inverted in polarity. So, and they're getting smaller as they are moving away from the source of the generator. Grid 4, 5, 6, they are normal polarity with N20 and P30. N20 going up and P30 going down. So we can see the phase reversal in between grid number 3 and grid number 4. Grid number 3, 2, and 1, they are all recording sensory response over the motor area. So these are not motor responses. So when we communicate with the surgeon, we say, okay, these are the, so we should never mention that these are the sensory motor responses. These are the sensory responses recorded over the motor area. So once we are done with the sensory mapping, we identify the central sulcus, and we know which context is coming from the pre-central gyrus. Now that's the area where we need to stimulate to get the motor responses. So we do direct electrical cortical stimulation by either utilizing those contacts which are on the pre-central gyrus, or we can use handheld stimulator and leave the contact grid there for electrocardiography. So if there's any seizures or epilepsy or any after discharges, we can identify. We have two methods. There are two techniques which we can use for direct electrical cortical stimulation. Technique number 1, which is being used since 1930s, is Penfield. Dr. Penfield developed and published in the 30s, and then Taniguchi, which was published by Dr. Taniguchi in 89 and 91. So those are different techniques, two different techniques, and these techniques have evolved over the last many years for intraoperative cortical and subcortical mapping for the mapping of the corticospinal tract. The difference between the two is the stimulation method, the pulse width, the frequency, the type of stimulator probe you are using, monopolar versus bipolar, and the active, which one we are using, active, anodal, or a cathodal. So we use anodal. So either of these two methods can be utilized based on tumor location, pattern, and surgical procedure, and other factors which are key factors which affect the responses we can record from the contralateral muscles. So when we are doing these direct electrical cortical stimulation or cortical motor mapping, these two techniques, so Penfield technique is a low frequency, uh, is a long pulse, low frequency stimulation. Taniguchi for cortical stimulation is a short pulse but high frequency. For the subcortical mapping, again, is a short but high frequency. So incidence of intraoperative seizures or after discharges occur is higher with the Penfield method because the stimulation duration is much longer. It's in few seconds, 2 to 5 seconds, comparing to Taniguchi, which is very short pulse for a few microseconds. So it's very short for a few millisecond duration comparing to Penfield, which is done over the period of second. So the risk of intraoperative seizures are much lower in Taniguchi method as compared to the Penfield method. But when we are doing language mapping, we have to stimulate for a longer period of time. Or if you're not getting a response with the Taniguchi, then you may be able to switch to the Penfield method to see if you can do the correct mapping. So here we can see technique for the Penfield method. For the Penfield, we use a bipolar ball tip electro probe. We use either 50 or 60 hertz stimulation. The pulse duration is 0.5 to 1 millisecond or 500 to 1000 microsecond. You can use a lower if the patient has a risk of seizures. You can start from 200 microsecond or 300 microsecond and then go up. The duration of stimulation is about 3 second to 5 second continuous stimulation. So if you're doing 50 hertz for 5 seconds, that's a 250 stimuli. So when we are stimulating, we identify the motor area and the contralateral face, upper extremity and lower extremity, and then put a marker on that. So when the surgeon is dissecting the tumor, we make sure those areas is continuously being monitored and they're not affected by resection. So this is one of the example of recording from Penfield method. So we have three windows always. We have our spontaneous EMG on the left side, and then we have direct electrocortic responses, triggered EMG response, and then we have electrocardiography running at the same time. So because we want to do electrocardiography, so make sure patient doesn't cease, or if there's after discharges, we can apply the eye saline quickly to prevent the spread of seizure to the whole brain. Here we can see the stimulation artifact, which is so 1, 2, 3, 4. So the duration of the artifact lasts for 4 seconds. So we have this as 4-second stimulation with no after discharges, and we can see the responses. And here you can see is the train stimulation with 4.3 milliampere current. So we have very good responses at 4.3 milliampere. And all these responses are about 20 millisecond apart because the sweep is 10 millisecond per division. So if you're stimulating 50 hertz, that means 1000 millisecond divided by 50, 20 milliseconds. So the ISI of 20 hertz stimulation is 20 millisecond, and you are going to see all the responses, multiple responses, 50 responses in 1 second window. So I have squeezed this, make the window shorter to zoom in. So this is one so this is 10 millisecond per division, so we have 100 millisecond window. So we are getting only 5 responses because there are only 5 stimulation and 5 responses in 100 milliseconds. So and 50 in 1 second. So if you change the view or sweep to 1 second, so you'll be able to see all 50 responses. And it's always good to have the video connected, like you can see on the left side top and the right side. They are bipolar probe, which is in touch, in contact with the patient cortex. Now, on the other hand, the other method, Taniguchi method, which was published in 1993, is a high frequency train with a short duration, and it can be done by bipolar stimulation and monopolar stimulation, but the research shows that a monopolar stimulation has a much higher threshold, much higher response, or low threshold response. For the cortical stimulation, we use monopolar in the anodal mode, and so the references can be placed in FPZ, LFC, and then you can stimulate with the probe in hand. And when we do the subcortical mapping, then we have to do cathodal stimulation. So you have to switch in the software, so you don't have to unplug it. So in the software, you can just switch the polarity and use the cathodal stimulation for subcortical, but anodal stimulation, and it has to be constant current. Constant current anodal for stimulation for cortical stimulation, and constant current cathodal stimulation for subcortical stimulation. The frequency ideal frequency is between 250 and 500 hertz. You can go up to 1000 hertz, but that's a good frequency, and then you can start. This is and you can go up to 20 milliseconds. That's the maximum you can stimulate. So when you're doing the subcortical mapping, so we use Taniguchi method again, which is a continuous subcortical mapping while the surgeon is resecting. The reference used for subcortical mapping is that the rule of thumb is that 1 millimeter is equal to 1 milliampere. So if you get a response at 5 milliampere, that means the corticospinal tract are about 5 millimeter from that distance. And this is if the patient is not paralyzed, it has no muscle relaxation. The anesthesia is ideal. It's a total intravenous anesthesia, no propofol, or patient is awake. So that we use, and this does not apply to the cortical stimulation. It's only for subcortical stimulation. And for subcortical stimulation, we want to stay as far as possible. So we start with a 10 milliampere, and if you get a response, you go down, and if you don't get a response, you can go up to 20 milliampere, and we increase the 2 milliampere, 10, 12, 14, 16. If you get a response at 5 or 7 milliampere, then it is recommended to stop resection, because you are less than 5 millimeter from the corticospinal tract, and if you do any more resection, there's a high risk of that you are going to cause damage to the cortical. And if it's less than 3 to 5 milliseconds, there's very high probability patient will have a motor deficit at the day of surgery and a day of discharge, and the long-term discharge. So it's better to stop between 5 and 7 milliampere. So here we can see again, just like Penfield method, we have 3 windows. On the right side, top right side, we have spontaneous EMG. On the left side, we have trigger EMG, a motor evoked potential, and at the bottom B is your electrocardiography. So this patient, we are not getting any spikes, any after discharges, no artifact in spontaneous EMG, but on the trigger EMG, so we have only five pulses, and we see a response in 2 muscles, flexor carpi ulnaris and abductor pollicis brevis. So this is close to the hand area, and for Penfield where we see multiple responses, so if you have 1 second window, you see 50 responses. With the Taniguchi, we are stimulating as MEP response as we do transcranial MEP, but a direct cranially instead of constant voltage, we are doing constant current, and we see 1 single response in response to the stimuli. So here, this is a summary of the difference between Penfield stimulation and long pulse, slow frequency Penfield on top, which is 50-60 hertz, and the ISI is 50 hertz, the ISI is 20 millisecond, and this is a Taniguchi method. We're only using 5 pulses and then 5 pulses again. And for the Penfield, we see multiple responses over a period of second, and in Penfield and in the Taniguchi, we see only 1 response to single stimuli. So this is electrocardiography EEG recording direct from the cortex in response to Penfield stimulation. So we are using 8 context grid, so 1 to 2, 2 to 3, 3 to 4, 4 to 5, 5 to 6, 6 to 7, and 7 to 8. The last channel at the bottom, we see very high noise, and the reason is that if you're using 6 contact or 8 contacts or 4 contacts, many times the last contact, which is close to the cable, it is not fully touching the, especially for longer grids, so it is not touching the cortex, and you may see a poor impedance. So here this contact number 8 is very poor impedance, that's why we get the noise. Here on the green arrows, so we see the stimulation artifacts, and on yellow arrow, this is pointing to your after discharges. So patient is having after discharges only in 1 channel, There may be a little bit in third channel, but the channel 1 is very clear spike and waveform. And so these, each electrode is about half centimeter from here. So it's a very focal start of for after discharges, and if you stop that before step to other channel, we can do the local. So what we use, and we use 16 ice saline, not cold saline. So we use a slushy machine, we apply locally, and because once it's spread beyond the exposed cortex, then you have to use intravenous medication to stop the seizures. Otherwise it's going to keep will not be able to stop with that. So again, electrocardiography of another patient, you can see stimulation artifact, which is followed by the spike, and these seizures they're getting faster, and at the end of the few seconds, within 5-6 seconds, you see the patient is in convulsion, and you see muscle artifact as well. So if you see muscle artifact, that means the patient is convulsion. So now the very important part is alert criteria. So what is the alert criteria where we can say, okay, there's a change? So the alert criteria is very similar for both transcranial motivopotential and direct cortical motivopotential, but a little bit different. So for TCeMEP, we are looking at three things: amplitude, morphology, and threshold of the response. So we don't use 50% drop in amplitude for transcranial motivopotential because there's too much fluctuation in TCeMEP response. And if you use the 50% criteria, we will have a lot of false positive. And we don't want to use a total absence of response, which is all in none phenomena, because that means that muscle motor response are already gone. So that's too late. So we use about 70 to 80% drop in amplitude is a significant change, and surgeon should be alerted. We also look at a morphology. If the change in morphology, if you're stimulating 6 pulses and you have 6 responses in CMAP, and it's from change from 6 to 2 or 1, that means there's a significant change and all the D waves are not transferring to the muscle. And then threshold, so the last one is a threshold. So during the surgical procedure, if you have to increase more than 100 volt to get the same response we were getting at the previous threshold, that means something wrong. So one of them, two of them, or three of them, different combination, but those are the different three things that we have to look at criteria for that. For direct cortical stimulation, we stimulate at the lowest threshold. For the MEP, transcranial MEP, we use at above the threshold. But for direct electrical cortical stimulation, we only stimulate a threshold. We don't go above the threshold. And the alert criteria is 50% drop in amplitude. For subcortical stimulation, 1 millimeter is equal to 1 milliampere. And then we want to keep the responses above 5 milliampere. So if we reach 5 milliampere response and we're getting responses from 5 milliampere or low, that means we are too close, 5 millimeter close to the cortical spinal tract, and that's a time where we have to stop. Regarding anesthesia, again, there's always a discussion to use DIVA or inhalation agent. So neurophysiological monitoring and adequate anesthesia must exist in the OR for getting the best response. So the decision is always to make the best responses. And why we care about having a good anesthesia, we are there to monitor, but anesthesia is not part of our field. But again, we want to get responses. We want to have good signal to noise ratio. We want to have reproducible signals. We want to have minimal variance, and we want to be able to interpret the data and convey the right information to the hospital, to the surgeon and anesthesia team. So if the anesthesia is stable and we don't have any effect of anesthesia, then we are able to do all of them. So for transcranial electrical motor potential, we always prefer to have total intravenous anesthesia unless the patient has any allergy to propofol or something, and we cannot use that. But the preferable anesthesia is TIVA, which is no inhalation agent, no nitrous, only propofol. But if using propofol, then we should have about 50 to 150 or maximum 200 microgram. A propofol with 300 or 400 microgram is not going to help us. We can use fentanyl or remifentanil, very low dose, no muscle relaxation, and train of force should be at 4x4, because even if it's 4x4, you can have a higher number of muscle relaxation. So we want to have, we don't want 3x4 or 2x4. So always make sure we have 4x5 electrode and keep checking trainer 4 throughout the surgical procedure. For direct electrical cortical stimulation, again, recommended is TIVA with propofol, no muscle relaxation, less than 200 or less than 150. The other, if the patient, if we are doing like cortical stimulation for awake surgery, for language mapping or other any case or epilepsy, or where we have to keep the patient awake, or have to, you can see, induce the patient, have the patient in sleep and then wake up and then go. So we use sleep awake sleep awake. So where person is sleep awake sleep, patient is sleep, then we wake up the patient and then patient do the testing and then the patient go to sleep, and then uh, we close. So the surgical application, what type of surgical areas we can apply TCeMEP, and why? Because the point is you have to select the correct technique for best patient safety, minimum false positives and false negative, and for more surgical precision and total resection. The three major benefits, we have long list of benefit of doing the intraoperative monitoring, but the three main benefits are increased safety of the surgical procedures, increased ability to accommodate more complex procedures, and decreased risk of post-operative surgical outcomes. So those are the three things that we are looking at there. For TCeMEP, we can apply to different neurosurgeries: brain stem tumor, aneurysm, spinal tumor, peripheral nerve, spinal cord stimulator, for collision study, tethered cord, rhizotomies, cardiovascular surgeries, CABG, aortic surgery, carotid surgery, TCAR, and then orthopedic surgery, all type of spine surgery, scoliosis, hip surgeries, tibial osteotomy, shoulder surgery, and even for parotid surgery, thyroid surgery, facial nerve tumor in ENT, where we can do corticobulbar MEP and monitor the path of the motor pathway while the surgeon is operating. So for for direct electrical corticostimulation, they are highly recommended for all surgery which are supratentorial. So transcranial motor evoked potential are not ideal for supratentorial because we have no control on the spread of the current. So if you're doing a supratentorial surgery, so there's a risk of you're stimulating below the surgical side, and if the motor fibers are damaged, you're still going to get responses because there's no blockage between activation and the recording muscle. So for supratentorial surgeries, only direct electrical cortical stimulation and no TCeMEP, and infratentorial you can do TCeMEP. Aneurysms and cortical stimulator implant, language mapping, all these we do direct cortical stimulation. So the surgical application for MEP and DCS, orthopedic surgeries, so lumbar surgeries, trauma, as you see here, trauma, tumors, fractures, spine surgeries where this trauma involved, spine deformity surgeries, scoliosis surgeries, kyphoscoliosis surgeries, vertebral column resection, which we see this patient, we published this paper, um, and again scoliosis cases and ACDF, posterior cervical, all the cases which are done on the spine. Spinal cord tumor surgeries, intradural, extradural tumor, intradural, intramedullary tumor. All these surgeries, they put the patient at risk for low limb sensory and motor function. And if it's a high cervical level, then all the four extremities are at risk, including bowel and bladder function. For spinal cord tumors, the best modalities recommended is doing sensory evoked potential, motor evoked potential, spontaneous EMG, trigger EMG, D wave recording, dorsal column mapping, sensory and motor mapping, and corticospinal cord tract mapping. Change etiology, ischemia can cause changes, cord manipulation can cause changes in the signal, direct injury to dorsal column can make some changes, and direct injury or resection of corticospinal tract can also result in changes. So we have to be aware of those. Spinal AVM embolization. So if any patient has an AVM and that has to be embolized, so we publish this data where we use propofol and lidocaine for just like the spinal water. So if you want to embolize, you have to make sure all the vessels, they are not vital to the corticospinal tract. So we inject lidocaine and then we inject propofol one at a time, and then the MEP and SSCP, and if there's no change, then those vessels can be embolized. If there's a change, then you have to spare those vessels. If there are 3 or 4 vessels, then that one of the vessels has to be left alone. Split cord surgery, tethered cord surgery, they also put the spinal cord at risk. So having motor evoked potential, transcranial motor potential in these cases are very helpful. We don't do direct electrical cortical stimulation because that's only for brain surgeries where the brain cortex is exposed. So here we can see the split cord, two cords, and there's a spur. There was a spur which was removed. So the spur is removed here, and then we are trying to. So the other tether cord release case, again, tether cord release case can be with lipoma, myelomeningitis, myelomeningitis, and all these we can do motor evoked potential in addition to bulbocavernous reflex and SSCP and EMG. All these, this procedure you can see have spontaneous EMG, trigger EMG, and train of 4. But addition of total motor evoked potential can also be helpful for conus, protection of the conus, and also for direct nerve root injury. So the recent literature suggests that motor evoked potential in lumbar cases are more beneficial for nerve root injuries as compared to sensory evoked potential. For spinal cord stimulator implant, so if you're doing spinal cord stimulator implant, if this for the lumbar we do only trigger EMG or EMG, but if the patient if we are doing spinal cord implant at thoracic level or a cervical level, or you're doing intramedullary tumor at that level, we can use motor evoked potential as for collision study. Collision studies, we are trying to find the left and right side or midline. So we place the grid, the spinal cord stimulator, we turn on the external battery, and then we run motors before and after that. If we are on corticospinal tract on left side, we will see drop in amplitude on the corticospinal tract, and if it is on the right side, we'll see the change because of the collision. We can also do direct the spinal cord stimulation with the motor stimulation, and can get responses from the muscle, and that give you the same information. Orthopedic surgery, tibial osteotomy, and fibular osteotomy. This is one of the patients we published, where there's a high risk, up to 50% risk of foot drop. So having a motor evoked transcranial motor evoked potential can prevent and can identify any changes in the function of the peroneal nerve or tibial nerve. Orthopedic surgeries, shoulder surgeries, they're also high risk surgery where especially musculocutaneous nerve and axillary nerve and radial nerves are at risk. Median and ulnar are less at risk as compared to the other axillary and radial and musculocutaneous. So we can do motor evoked potential for all 3 head of the deltoid and biceps and all the muscles, and we can identify the changes. If the patient has high BMI, has weight like overweight, and we have a lot of adipose tissue, then we can also use longer needles. So if you want to study more, read more about that, so this is a paper we published in 2019 about comparison of the regular, these yellow needles are the regular 13 millimeter, they are not fully in, as compared to 50 millimeter, 37 millimeter, 25 and 18 millimeter. So we did study in multiple centers in a few different countries, and we had about 90%, 87% risk of, 90% success rate in longer needle 37 and 50 millimeter, as compared to 50 millimeter we have 100%, 37%, and 37 millimeter we have 87% success, and 13 millimeter we have only 13% success. So if we have used 13 millimeter, we have not gotten a signal in about 87% of the patients. If we use 18 or 25, again we could have missed all those motor, or had to stimulate so high the patient be jumping and surgeon stop that. So we were able to get these responses at a very low current. So other cases with spinal dystrophism, spinal cord tumors, and there are other publications we saw the benefit of using transcranial motor evoked potential in these cases, shoulder surgeries, and also hip this bladder surgeries, where we can see motor be tested first paper published with using single train and double train MEP, and we were able to record very good motor evoked potential uh, from the from the urinary sphincter as compared to anal sphincter muscle, because um, if you are until now we were doing anal sphincter monitoring for EMG and MEP, assuming the pudendal nerve is intact, but there's a still risk of damage to the fibers going to the bladder with intact sphincter muscle, anal sphincter muscles. So a patient can wake up with urogenic bladder and they have to wear the diaper for the rest of their life. So, but if you are doing adding motor evoked potential and trigger EMG using the bladder electrode, that can help in these cases. Cranial nerves, so brainstem surgery, fourth ventricle tumor, CPO tumor, corticobulbar MEP. Corticobulbar MEP can be done by transcranially, and if the brain is exposed, so you can do direct cortical MEP. But most of these surgeries are CPA tumor where we don't have cortical exposure, so we can do we don't do transcortical stimulation. Sorry, we do transcortical, but just one lobe at a time. So either you do left side stimulation or right side stimulation, CZ to C3 or CZ to C4, where CZ is always cathode and C3 and C4 are anode to the opposite side. And we do with a double train, so you can see single train and double train, because when you do transcortical stimulation, there's the current spread to the skin. It also activates the muscles, and you can get a response from the muscle contraction. In this picture, you can see this is a single pulse stimulation. There's a 3 pulses, and we're getting response after single pulse, and then we are getting after 3 pulses. So theoretically, when you stimulate the single pulse, it does not cross the corticobulbar tract. So this is a corticobulbar tract, this red one, and so upper motor neuron makes synapse, and the lower motor neuron and supply the muscle of the face. So if you do single pulse, it's not going to cause any muscle contraction. Same as the limb muscles. So if we do, that's why we do train stimulation. We do single pulse stimulation. We can get D wave recording from spinal cord, but we cannot get CMAP responses from the muscle. So we have to do train stimulation. So, but the current spread, you can get a response from the peripheral response from current spread with a single pulse. So that's why we do single pulse and train. If you get response by single pulse and train, that means there's a current spread. So you change the stimulation, you decrease the stimulation intensity or decrease the number of pulses or decrease the number of pulse width until the single pulse disappear, but the train does not disappear. So here we can see the loss of responses of the single pulse, but intact motor responses of the pulses. So now there's no current spread here. On the above that, we have current spread on both sides, both ocular oris muscle and mentalis muscle. So all the patient with the cerebral CPA tumors, small size, big size, they put the brainstem at risk, motor function, sensory function, auditory function. So we adding TCeMEP, corticobulbar MEP is very beneficial. Here is a case where is ENT case. So we can see the ENT case where the surgeon is stimulating with a probe. So normally when we're doing ENT, all the parotidectomy patient, the surgeon is stimulating and we are depending on the surgeon to stimulate. So either you can put a hook electrode on the root of the facial nerve and do continuous trigger EMG, or you can add corticobulbar MEP. So you don't have to wait for the surgeon. That surgeon is going to stimulate after 10 minutes or 15 minutes. So you can do every 1 second or every 1 minute corticobulbar MEP, and you can keep monitoring in addition to TCeMEP. So here we can see parotidectomy, ENT surgery, where we're using transcranial motor evoked potential with single pulse and train pulse. And on the left side and right side, so we are recording from two oris and mentalis muscle, and we have a single pulse stimulation and train pulse stimulation, where we are getting responsive with a single and train pulse stimulation. So we should not be getting after single pulse. So we decreased. I decreased the pulses from 5 to 3, still getting some responses, and then decrease the current stimulation, and then the single pulse disappear. So when the single disappear, that means that those are the pure motor responses. Thyroidectomy. So again, thyroidectomy for thyroid surgeries. So we can monitor superior laryngeal and recurrent laryngeal nerve, and we can do corticobulbar MEP from these cases. And having a corticobulbar from thyroid surgery will give us a continuous monitoring in addition to the trigger EMG, which is more mapping, is not a continuous monitoring. If you want to do, so we want to do monitoring and mapping for all these cases, and the only way we can do is adding a corticobulbar MEP for lower cranial nerve EMG. So vagus nerve we stimulate, and then we can see responses. We have to have a train on single pulse, both of them. You can do single pulse and train, you can do train or single pulse, and both are fine, but you have to make sure you are adhering to correct parameters and inter-train interval. So brain surgeries again, if there's a brain surgery, so it's a cortical tumor, is you can see the central sulcus on the opposite side, but the surgical side or tumor side, it's affected. So functional mapping can help, and this can be useful only with direct electrical corticostimulation. In these cases, we don't want to do transcranial motor evoked potential because if we have a risk of false negativism, also false negative, which is not good for the patient and for the surgeon. Language mapping. So if you're doing language mapping, again, we do direct cortical stimulation for disruption. So we want to identify Broca's area and Wernicke's area. And if you do stimulation, it can cause aphasia or hesitation or slurring. Or if you're doing the stimulation, we are very close to on the Wernicke's area, it will cause impaired speech, again hesitation, and non-fluent speech. So we can identify exactly which area the surgeon is stimulating, and we can minimize the deficit. So uh, adding of the multimodality monitoring can help us in identifying different type of even just position or changes in the spinal changes. So these are hundreds and hundreds of publication which proves the benefit of monitoring and finding the alerts which can help in reducing the patient in different to SSCP. So for direct cortical stimulation, again, there are different models and different concepts. So Taniguchi versus Penfield, so you can use any of them depending on the patient and what you are trying to achieve. Here we can see some TCeMEP, transcranial motor evoked potential, where there's a loss of drop in amplitude, and then surgeon was alerted, we increased the blood pressure and all manipulation, the signal came back, and then we have lost again, and there was a lost, and then signal came back at the end. Um, so high risk surgeries outcome with monitoring, we have least out post-operative deficit, and we have better outcome if you are using no IONM, no monitoring, or if the monitoring is there but poor monitoring, then outcome are very bad. So we want to make sure if we are providing the monitoring, we have to have a high quality monitoring. We don't want to do a poor quality monitoring because then you are the education of the person who is in the OR, their training, their expertise, their certification is critical. So neuromonitoring is not bad, but it's the person who's doing the monitoring. So sometimes I talk to the surgeon, they say, okay, I used monitoring and my patient was paralyzed. I don't want to use monitoring. So it's not the technique, it's the person who's doing that. So you have to make sure we are offering with the best monitoring and not the person. So in conclusion, evidence practice of neuromonitoring, try to do evidence-based practice, use the stimulation regarding parameters, the type of stimulation, type of monitoring, type of motor evoked potential, cortical, subcortical, depending on the evidence. There's already evidence of value of neuromonitoring in many types of surgical broad scope. Data on video neuromonitoring must continue to gather so we can still use gather for all different types of surgery where we are not being monitored, and new model of research will lead to better understanding of value of neuromonitoring for these patients. So MEP and transcranial motor potential and direct cortical motor potential both are excellent tools for recognizing intraoperative neuro changes uh, to minimize post-operative deficit. So a multi-modal, so even these are motors, but still multi-modality approach is the best approach, and it should be utilized with sensory evok potential, motor evok potential, EMG, auditory evok potential, cranial monitoring, depending on the type of surgery for the best, for the maximum resection, maximum correction, and best outcome. Training workshop training is critical. So having hands-on training in pre-operative area in clinical setting where whoever is doing that, you don't want to go into war and try to practice for that, should be able to do the practices in the clinical setting on volunteers or dummies or a software. It's a software and technical, and then when you go to the OR, so we have more training in the OR because whatever technique you want to use, you want to make sure that you have some senior neurophysiologists. They can hold your hand and you help you placing the electrode, and you're not just doing any technique by just watching a video or lecture. Thank you again, and thank you for listening, and it's a pleasure